Hi everyone, I'll be presenting the findings of a qualitative case study we did on the use of incentives in the care of people at risk of living with HIV in BC. I just want to acknowledge my co-authors here. The outline that we'll go over include incentives in healthcare and HIV care, a very quick summary, setting the stage for our case study, presenting our sample, a very quick overview of our findings and conclusion. And if you want more details on the study, we already have 2 papers that have been published that provide so much more information than I can cover today. And of course, I would ask that no one takes pictures of the slides, just simply because they include quotes from our participants. Incentives in care have actually, there's been such a growth in interest around this. And the idea is really rooted in behavioral economics. So how can we increase the perceived reward of some behaviors and then encourage people to either change their behavior or achieve some health outcomes. And they've been used in a range of settings and with various behaviors, whether it's immunization, weight loss, treatment adherence, clinic visits. And in HIV, they've been also used to really boost the HIV cascade, whether it's at the level of prevention, testing, diagnosis, treatment adherence, viral suppression, and engagement and retention in care. There's kind of 2 categories of incentives. Positive incentives, the goal is to encourage and reward the target desired behavior or measurable outcome. For example, giving someone a $20 monthly cash payment to complete an immunization schedule. On the other end, negative incentives, the goal is to discourage or punish, quote unquote, some undesirable behavior or failure to meet an outcome. In this case, it could be withholding the chance to take part in a draw because you have a positive urine drug screening test at a clinic visit, for example, or increasing taxes on cigarettes is another example of a negative incentive. And in our study, participants really had experience using a range of incentives, whether it was cash, gift cards, prize draws, vouchers, and fishbowl contingency management, and also food. And so there was a range of incentives across our sample. There's been some gaps in research. Most of the research has been focused on acceptability from a general public perspective, rarity of patients and providers, and the effectiveness of incentives. Research has shown that incentives can have a positive impact on health outcomes and care management, but they do have and can have a negative impact on the therapeutic relationship. And there's definitely more research needed to look at the emerging ethical issues in doing incentivizing in practice, which there hasn't been a lot of. So to address this gap, especially in the field of HIV, we decided to do an instrumental case study. It's a qualitative studies. And what's interesting with qualitative study is that you can mix a range of data sources, which we did, and you can learn a lot from a case study and then can not necessarily generalize, but try to understand a phenomenon, in this case, incentivizing in healthcare. And so why pick HIV in British Columbia? Because there's quite a bit of people living with HIV in the province. The province is also known to have been a place where there's been a lot of high impact initiatives implemented and incentives have been used. So what we did is we interviewed 25 participants. They included healthcare providers and also service providers. The majority of them had experience in the field of HIV for 5 to 10 years. We were looking for people that had experience of at least 5 years and at least one experience of working with incentives. But what turned out to be actually is that participants had more than one experience and had used a range of incentives in various roles. So in various jobs and different settings, which provided some richness to the data. We also interviewed key informants to try to tap into their expertise and provide some helpful insight around ethics, law, policy, and research. We actually sent out 19 invitations, but only 6 agreed. And those who refused cited lack of knowledge about incentives, what I think is revealing in and of itself. So what came out of our study is that there were some interesting contextual influences in BC that has been favorable to the implementation of incentives, including 3 big things. One being the launch and scale up of Stop HIV/AIDS. The second being blurring of the lines between research and care, and the transactional nature of survival economies. And especially if you look at the quote to your left, the idea that this idea of transactional logic already existed and that a lot of the people that are the most at risk for HIV or people that are being targeted by incentive programs tend to be people who understand the transactional nature of either participating in research, and that logic was transferred into care. So they understood that, you know, if you do this thing, you'll get something in return, and that was already well established. We identified that the, you know, incentives are not applied across the board. They're definitely prioritized for certain populations based on the risk that they face or the risk that they pose to others. It is very much embedded in a public health perspective, and the profile of target populations were definitely people who were struggling with concurrent health conditions, that were street entrenched and living in poverty, living chaotic, busy, complex lives with a clear focus on survival. As I've mentioned, deeply rooted in a public health logic, the idea of incentives being to drive the numbers up and drive the number of cases down. And providers definitely spoke of a tension between the desired outcomes of incentive program being more top-down and measurable versus their own outcomes, which tended to be more bottom-up and relational. Providers spoke of the limited effectiveness of incentives. They did acknowledge that they work to some extent and that they turned something that was not a priority into one. So for example, if it's not a priority for you because you're living a very complex life and with different, you know, competing priorities to come to the clinic that day, that you will end up showing up because there is an incentive at the end of this. It definitely got people through the door, it broke the ice, and it sent a signal that time mattered and that time is money in this case, especially when you are in more of a survival mode. But providers acknowledge that incentives are superficial, they increase metrics of success, but they don't really fix the underlying problems. They're short-lived and one-dimensional, and that once the incentive stops or people get used to them, they also stop working, and they consider incentives to be band-aid solutions and that they don't really address the broader determinants of health. And then they question if incentives were actually the right tools to use. They cited some unintended consequences, including the complexity of having to administer incentives when they are not necessarily included in the design and implementation. A good example of that is the difference between often programs that use gift cards when in fact providers prefer to use cash. They thought that it was more of a supportive, flexible, less paternalistic approach, but they were often just given gift cards to give out and not included in the decision-making process. They cited some safety concerns for themselves and some clients, especially when clients are receiving incentives and then going into the community where maybe they owe someone money, for example, and that can create a dynamic. They cited also the sense of inequality among the community and having to do a lot of triaging and redirecting for people who are not eligible, and that they were worried about sending the wrong message, like linking heightened HIV risk to more support and money. They also were concerned about the impact on the relationship, that it felt more transactional and intensified power dynamics, and worried also about engagement in care, and that, you know, whoever gives out incentives in the community has more retention, and then that can lead to less retention for programs that are not able to provide incentives. They also mentioned professional and ethical tensions, including a bunch of added responsibilities that they weren't prepared for, a lot of complexity around managing the incentive, the transaction, and the relationship, trying to balance the harms and benefits, trying to keep the relationship feeling relational rather than financial, and really trying to develop strategies to make sure that they felt that the practice did not go at odds with their professional values, standards, and goals. They did mention quite a bit of issues around free and informed consent. I think because of the time limit, I can't really go in depth, but they developed also a bunch of strategies to make sure that they were trying their best to assess the person's consent to whatever they were taking part of from a care perspective. But they did hear quite a bit from their clients that they just wanted to be signed up, or they just wanted the incentive, and acknowledged that there was a risk of coercion, but also felt that it was very hard to determine what is coercive in this kind of situation. And I think the quote speaks of the struggle that can pose for providers. In conclusion, I think the quote by Klein here to your left is revealing of I think what we're taking away from this case study, which is it's very hard to determine if this is in fact a health intervention and not simply an economic intervention. And if this is actually like part of care, rather more of a public health intervention. I think there needs to be more looked at incentives in practice, meaning the implications for providers, from a relational care and critical ethics perspective, there needs to be more tackling and investment in the root causes of the issues and not simply a band-aid solution. And of course, just concluding on a note around questioning the convergence between HIV cascade and market logic, which, you know, is something to be further questioned. And there's very literature on this. Thank you.